So, let's do another round of anatomy and physiology with Dr. H. While we're stuck here at home, we might as well learn a little bit of physiology, right? So, today we're going to focus a little bit more on the urinary system. And we're going to dive right down into that nephron, right down into the functional unit of our kidney. And by functional unit, what we're talking about here is this is where most of the physiology occurs. This is where the function of the kidney is primarily occurring, and the function of that kidney is filtration. We want to filter things out of our blood, lots of it, 180 liters per day, and we want to reabsorb most of that back into our blood. By the time it leaves the nephron, we need to make sure that most of that material gets back into our blood, otherwise we're peeing 180 liters a day, and that doesn't sound very good. In addition, there are some things that are going to be too big to filter, so we're going to need to secrete them from the blood back into our tubules. And the way this all pans out is with a relatively simple equation. Whatever gets excreted through these tubes, whatever is going to come out in the end, well, that's going to be equal to however much we put into the system. And we're putting filtration into that system, 180 liters of filtration or filtrate every day, minus whatever we take back out. Okay, we're only going to excrete whatever we filter minus whatever we take back out. Well, we're going to be able to subtract out whatever we reabsorb, whatever goes back into that bloodstream. Then we're going to be adding back in just a little bit, some big things that need to get secreted from our blood that don't get filtered. We need to actually still get rid of them. So we still need to get them into our urine, so we're going to secrete them. And this formula kind of summarizes the entire nephron. In my opinion, if you learn this formula and learn what each piece of this puzzle means, you can pretty much diagnose a large majority of kidney diseases that are out there, and think about kidney function in a completely different light. Let's do a quick little synopsis of what I'm even talking about here. Okay, we could do that with a diagram so we understand this a little bit better. And what we're going to do is draw just a really simplified nephron. Okay, we're going to say we have our Bowman's capsule. We're going to have the afferent arteriole entering. Try to always draw in that the afferent arteriole is bigger than the efferent arteriole for reasons that we're going to discuss. Now the Bowman's capsule has a tube that can leave it. So let's just draw in that tube. Yes, it's convoluted. Yes, it dips down into the nephron loop. But let's not worry about that for now. Let's just draw one big long tube and we'll say this is the entire tubular system. This is the PCT, this is the nephron loop, this is the DCT, this is even going to be the collecting duct. So let's say we got this entire system right here. Okay. And we say blood supply enters through the afferent arteriole. It goes through the glomerulus, which is basically just a bunch of squiggly lines, right? It's kind of a spaghetti, this modified capillary bed with lots and lots of fenestrations. And then it's going to leave through the efferent arteriole. Well, let's look at our formula. In order to get urine out over here, in order to have excretion, what do we need to do? Well, first we need to filter. The very first thing that needs to happen is filtration. Where does that occur? That occurs right here, between the glomerulus and the Bowman's capsule. And all of this filtrate is going to end up funneling out because it has nowhere else to go, and it enters the tubular system. We filter 180 liters every day right here. Where does it go? It's going to get reabsorbed. Right? It's going to get reabsorbed. It's going to end up, most of that, we're not going to pee that out. So we need to get this material out of the tubes. We need to get it out of the tubes. We need to get it out of the tubes. And how are we going to go about reabsorbing this material? Where does it need to go? If we're reabsorbing, well, we have to get this stuff back into the capillaries. So the capillaries, the efferent arteriole now, the capillaries wrap themselves around the tubes. Whether it's the peritubular capillaries or the vasorected, don't matter, right? Reabsorption is going to take things from the tubes and put it back into our blood. Our blood, in turn, is going to pump a few things back out. And these materials that are getting pumped back out are getting secreted from the blood back into the tubes. So we subtract reabsorption, we add secretion, and whatever's left over at the end gets excreted. And this is a really simplified view of nephron function that we're going to dive into in a little bit more detail. Because really, if you guys want to understand physiology, you have to understand how things work. Not why things work, but how things work. And formulas give us that ability to dive into how things work. Because we're not looking at math here. We're saying, if we want to pee things out of the system, how can we do that? First we have to filter, then we have to reabsorb, and we're going to add some secretion. So how do we filter? How does filtration occur? And that's what you guys need to ask next, is how does filtration occur? And I'm not a very good artist, as you can tell, so I'm not going to try to draw a whole bunch of stuff. What I'm going to say is that filtration occurs because of two reasons. Okay? Filtration is going to have two variables that control it. So this is going to be F right here. Filtration is one controlled by the anatomy of the glomerulus. Structure determines function, right? So the anatomy of the glomerulus is going to play a major role in how filtration can occur. When it comes down to the anatomy of the glomerulus, you guys can open up your textbook and you can see this. But the glomerulus has fenestrations. It has actual holes in it. It's a modified capillary bed with fenestrations, physical holes. In addition, right next to those holes is a membrane called a basement membrane. And the basement membrane, basement, talking and writing at the same time is hard. The basement membrane is unique because it is highly negatively charged. It's going to have lots and lots of negative charges on it. And negative repels negative. And so basement membranes are going to be really important for repelling large negatively charged proteins that potentially are trying to get through the fenestrations, but the basement membrane is going to block them from being able to be filtered, which is great because that keeps the proteins in our blood, which we want. The last little bit of anatomy that really helps with filtration at the level of the glomerulus is the fact that there's something called podocytes. Podocytes are the little cells that live on the glomerulus, and they help with filtration too. They're actually going to try to remove any proteins that are able to make through fenestrations, that are able to somehow magically make it through the basement membrane. Podocytes are going to be the last line of defense to try to prevent proteins from being filtered. And so it's this anatomy that is going to allow for filtration, in addition to a couple other things that we're going to talk about. Fenestrations. Picture a membrane. We're just going to draw a line. Alright, we got this membrane here, we got this capillary here. Inside of this, we got big red blood cells, we got smaller white blood cells, we got platelets and proteins. They're floating around inside of our bloodstream. And if there's no holes inside of that tube, these things and everything else is going to have a really hard time getting out. Perfect. Awesome. Now, let's add some fenestrations. Okay, let's take and put some holes. In our capillaries. Now what can go through? Anything that's small enough. What can go through a fenestration? Anything that's small enough. Is this big red blood cell going to be able to make it through? No. Are white blood cells and platelets going to be able to make it through? No. Are large proteins going to be able to make it through? No. The only thing that's going to make it through are things that are small enough. Sodium, potassium, glucose, bicarbonate, water, that sort of stuff can pass through these fenestrations really easily. So due to the fenestrations, due to the structure of the system, it's going to help promote filtration, because now we got these holes that's going to drive things out into them. We need to not just look at the anatomy of the glomerulus. That's all we've looked at so far. The other anatomy that we need to look at is the anatomy of the arterioles. So now when we're looking at the anatomy, you should also think about the difference between the size of the afferent versus the efferent. Arterioles. And why is that? What is going to happen here? Well, these arterioles have different sizes. The afferent is bigger than the efferent, which means more blood can flow in than can flow out. What this does is it creates a high pressure system inside the glomerulus. We create a dam, we block flow of fluid out of the glomerulus, and this builds pressure up inside of that glomerulus. So now we have two things really going for us. We have a high pressure system and holes. And as the pressure increases inside of the glomerulus, it's going to start to push all of this fluid out of the holes. Okay? Due to these differences between the size in the afferent versus the efferent, this is going to create a really high pressure, and we're going to call this hydrostatic pressure. And that hydrostatic pressure is inside of the glomerulus. So we're going to do a little subset glomerulus here. I'm running out of space. And we can abbreviate that as HP, capital H, capital P, lowercase g. This is hydrostatic pressure inside of the glomerulus, and that's going to come back for us here, okay? A primary driver of filtration will be the pressure of the water pushing against the walls of our capillaries. Beautiful little relationship going on there. Filtration. But there are some other things now that are going to affect filtration. There are actually some things in the system that can, well, oppose filtration. They're going to fight against filtration. They're going to say, no, we don't want water to leave the capillaries. We don't want water to leave our blood vessels. We want it right here. And these are the proteins I keep talking about. Okay, I'm going to draw my proteins in as stars because they're pretty darn important. The primary protein in our blood is called albumin. Albumin. This is the primary protein of our blood. It makes up about 60% of the proteins in our blood, and it's produced by the liver. Okay? It's synthesized and secreted into the blood by our liver. The liver, so important to so many things. Always the bridesmaid, never the bride. Most people don't give it as much attention as it deserves. This is a protein secreted by the liver, and this is what I call the party in the blood. Okay, this is the party. And by party, I mean particles. And by particles, I'm talking about whether water wants to go to where the particles are at. By party, I'm talking about osmotic pressure. Okay? Some of you don't know me. You're just watching this video for the very first time. I always call osmosis, I always talk about osmosis in a particular way. Osmosis, most of you guys have already learned, is the diffusion of water. But water is always trying to go from an area of high water to an area of low water. In other words, it's trying to go from pure water to salt water or water with particles in it. So whichever water has the particles, pure water wants to go there. And I just got into the habit of saying, those particles are the party. And water always wants to go to where the party's at. So where does water want to be? It wants to be where the party's at. So albumin is the primary party of our blood. It's the reason water wants to stay in the blood. And so as filtration is trying to push water out through these fenestrations, at the same time, the albumin inside of the blood here, this is trying to draw water back to it. This is constantly trying to oppose filtration. It's fighting against filtration by saying, no, 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 water, stay here. This is called osmotic pressure, the pulling pressure of the party. Peer pressure, right? And we're going to abbreviate this one colloid, because protein in a solution is called colloid. Osmotic pressure, COP. And this is also found inside of the glomerulus. This is proteins inside of the blood. And maybe you'll go back now and say, whoa, Dr. H, you were saying up here that proteins aren't filtered. Which is exactly what the body wants, because it wants to keep proteins inside the blood, because wherever proteins go, water is going to follow. So as long as the proteins are in the blood, water wants to be with those proteins. But if something happens and proteins make it outside of the blood, water is going to follow them. Water is going to follow them. And we can start thinking about that using a nice big equation. What we're really after when we're talking about filtration is we want to look at what the net effect of filtration is. We want to say how much filtration, after everything is said and done, how much filtration occurs. So what I was just talking about is that we can write a big equation for this that's called N net F filtration pressure. Net filtration pressure, which is the total amount of filtration after everything is said and done, that's going to end up going out into the tubules. And we can say, what is the primary thing that promotes filtration? Well, that's hydrostatic pressure inside of the glomerulus. So we're going to write that first. We're going to have a nice big hydrostatic pressure inside of the glomerulus. It's a plus sign. In other words, these two things are directly proportional. If hydrostatic pressure on this side of the equation increases, what's going to happen to our net filtration pressure? It increases with it, as long as this value goes up. If A was 1, the net filtration pressure would be 1, and if A went to 2, the net filtration pressure would be 2. So what happens on the right side of the equation affects what's happening on the left side of the equation. But now what did we say is always opposing filtration? That's going to be our colloid osmotic pressure. So we're going to oppose it. We're going to subtract it from the total amount of net filtration. We're going to oppose it, COP, inside the glomerulus. Awesome. Those are 2 of the 4 that we're going to be after in the long run. But they're the primary 2. They're the primary 2 factors. There are 2 other factors that we want to think about. Because if you think about where filtration is going, filtration, or filtrate is the fluid, is moving from the glomerulus into the Bowman's capsule. So now we have fluid in the Bowman's capsule that is pushing back against the glomerulus that entire time. We have fluid that's pushing against the walls. This is hydrostatic pressure. But it's not in the glomerulus anymore. It's water pressure, filtrate pressure in the Bowman's capsule. So we're going to do a subset C. And it is always opposing filtration. It's pushing back against the glomerulus. So we want to write in a C. I'm going to move my E up here for my excretion. Don't really matter where it's at. And the last variable that comes into play, I'm going to lead this off by saying this variable is normally 0. What is normally 0? Well, what did I say we normally do not filter? There's all these things that are trying to prevent filtration of proteins. So we don't normally have proteins out in the Bowman's capsule. But if there were proteins out here in the Bowman's capsule, wouldn't there be a party out there? And that would cause fluid to try to go from the blood towards that party. It would promote filtration from the blood into the Bowman's capsule. So we're going to add it back to our formula, and this is going to be COP. I'm running out of room, but this is colloid osmotic pressure inside of the Bowman's capsule. Again, this value is normally 0. Only if we start to filter proteins will that value change, and then it's going to have a huge impact on filtration. So let's look at this formula and see how we can use it. Let's use it. Let's abuse it to understand physiology. What did we just say? If hydrostatic pressure inside the glomerulus goes up, if somehow, anyhow, we increase the amount of blood flow into the glomerulus or decrease the amount of blood flow leaving the glomerulus, all of those will increase the pressure inside of the glomerulus, and so hydrostatic pressure would start to go up. And the second hydrostatic pressure inside the glomerulus goes up, what happens to NFP? It goes up as well. What about if a patient starts having issues with their liver, or for whatever reason, the amount of albumin in their blood decreases? This is called hypoalbuminemia. Okay, hypoalbuminemia, which is causing the party in the blood to decrease. So we're decreasing the amount of colloid osmotic pressure inside of the glomerulus. There's less party in there. As we get less of a party in our blood, there's less drawing power. We're not opposing hydrostatic pressure as well. So as COP decreases, because there's a minus sign here, we can think of this as inversely proportional or opposite to what's on the left. So as COP decreases, filtration will increase because there's less of a party in the glomerulus. Thus, there's less drawing power for water, so water leaves. What if the amount of water pressure in the Bowman's capsule were to decrease? Same idea. Then there'd be less pressure pushing against the glomerulus. Therefore, as the hydrostatic pressure in the Bowman's capsule decreases, net filtration pressure increases with it. Last but not least, what if a patient does have a disorder that causes proteins to enter the Bowman's capsule? It's going to cause proteins that enter the Bowman's capsule, which would cause the colloid osmotic pressure to increase inside of that Bowman's capsule. Thus, we're going to promote more water moving towards that party, moving from the blood into the capsule, increasing net filtration pressure. And this is how we can use a formula to describe almost any disease. Not every disease. We're going to get there with the next part of this lecture. But now if we have blood pressure issues, now if we have liver issues or any sort of protein issues in our blood, or we start to dilute our blood out too much with water, those sorts of things affect our colloid osmotic pressure. If we have kidney disease, then it's going to start changing these two variables, and all of those will end up impacting how much filtration we have. And if filtration goes down, then we start peeing less. And if filtration goes up, then we start peeing more. In other words, net filtration pressure is a major component of how much urine a patient is producing. As NFP goes up and filtration goes up, we will have an increase in the urine volume. So as blood pressure goes up inside the glomerulus, it will cause an increase in the urine volume of your patients. They will have frequent urination or polyuria. These are things you want to think about. Some liver diseases can cause polyuria. Why? Because some liver diseases affect the amount of proteins that are in the blood. We want to dive into this just a little, well, I want to dive into this just a little bit more. Maybe you don't, but you're going to get forced to do it. Eat knowledge and learn. Because ultimately, what we really care about in terms of filtration is not just how much net filtration pressure is there. We want to look at filtration over time. In order to do that, now comes in nephron function GFR. This is the penultimate of what we're trying to learn here. GFR stands for glomerular filtration rate. And rate tells us time, right? So this says how much filtration occurs over time. And there are two variables that affect our GFR. GFR, the amount of filtration we have over time, is going to be determined, one, by NFP. So NFP is going to be a major component of GFR. In other words, let's look at it this way. If hydrostatic pressure inside the glomerulus goes up, what happens to net filtration pressure? It goes up. So therefore, if net filtration pressure goes up, what would happen to GFR? It would also go up. So now we're going to have a patient with a higher GFR. The other variable that affects GFR is something called the filtration coefficient. Capital K, lowercase f. This is called the filtration coefficient. I'm going to say where Kf equals filtration coefficient. The Kf in the filtration coefficient is directly related to the surface area of your glomerulus. The bigger the surface area of your glomerulus, here's the way I like to explain it. Take your hand and put it in front of your face. Nice and relaxed, not clenched and not open. Take your hand and put it in front of your face. Imagine that's your glomerulus. Now, take that glomerulus and start spreading out your hand and spreading out your finger. What just happened to the surface that's now exposed to the world? Right? We're increasing the surface. So what do you think that's going to happen to the amount of potential filtration across that surface? It increases with it. So as the surface area increases of the glomerulus, this is going to make filtration easier. Now, take your hand and put it in front of your face and put it into a fist. What just happened to the surface area then? We just closed off the amount of surface exposed to the world around us. Therefore, there's less area for filtration to occur across, thus decreasing that filtration coefficient. The second part of the surface area has to do with the membrane permeability of the glomerulus. The membrane permeability is related to the anatomy. You've already learned this. Fenestration, basement membrane, and podocytes all relate back to the membrane permeability. And let's focus on the fenestrations, because we talked about that a little briefly over here. We said, hey, if fenestrations were bigger, what can pass through them? bigger things. Because what do we know about fenestrations? They're just holes. What can go through a fenestration? Anything that's small enough. So if we make those fenestrations bigger, what would happen to the membrane permeability? It would increase. So now take this same idea. Take your hand in front of your face and imagine you got a latex glove on your hand with holes in it. And then stretch that hand out. What would start happening to the size of the holes in that latex glove? That latex glove stretches and the holes stretch with it, thus increasing the size or increasing the permeability of that membrane. Now take that hand and relax it down, and as the latex glove relaxes, the holes become smaller. Therefore the membrane permeability would go down. Now hopefully you guys can see that the glomerulus, the surface area of the glomerulus and the membrane permeability of the glomerulus, they, in normal physiology, they will affect one another. So as the surface area goes down, membrane permeability will go down. And as the surface area goes up, membrane permeability will go up. And if either one of these variables changes, say for instance surface area increases, what would happen to filtration? It would increase. And as the filtration coefficient goes up, what happens to GFR? It goes up. And what is GFR? Ultimately, that's what we're looking at up here in this formula. Okay, this capital F, the filtration that we've been referring to this entire time, this is GFR. And NFP is just one part of it. The other part of it is the filtration coefficient. Hopefully you guys are doing okay. If not, take some time, study it, come back. Now, my teaching style says how. I'm always asking how. My students know this. I'm always asking how. How does something happen? How can we change GFR? This is what the body is trying to regulate. This is the Goldilocks of the urinary system. This is homeostasis. If GFR is too high, what's the body going to try to do? Bring it back down. Negative feedback loop stuff. If GFR is too low, what's the body going to try to do? Bring it back up. It's going to do everything it can to do that. How? If GFR is too low, what two variables can we change to bring it back up? What two variables? NFP and the filtration coefficient. So if GFR drops, how are we going to get this back up? What we do is the body is going to try through a negative feedback loops, trying to increase NFP, try to increase the filtration coefficient to try to get this back to normal, trying to bring GFR back up. So it's fighting using homeostasis, using negative feedback pathways all the time. How? How does it do this? And the answer is using hormones, autonomic nervous system, local intrinsic changes, and then there's emergency systems as well. There are a lot of ways that we can homeostatically regulate this material. Let's start with hormones. Hormones affect GFR. What major, lots of hormones will, by the way. We're going to list two major ones. Okay, the first major one is renin. Good old renin. And actually, let's list three. Renin, and we're gonna group in norepinephrine / epinephrine into one category. That's going to be our first category. And our second category over here will be atrial natriuretic peptide, ANP, which is a hormone that's secreted by the atria of the heart. Renin, norepinephrine, epinephrine, if you've learned up to this point, and I hope you have to some degree or the other, Renin, norepinephrine, and epinephrine are always trying to bring blood pressure up. So when blood pressure is low, our body's going to try to fight that and bring it back up. So when our blood pressure drops, renin and norepinephrine and epinephrine are going to help bring that blood pressure back up. Versus the opposite. ANP is going to be stimulated by an increase in blood pressure. When there's an increase in blood pressure, our body wants to bring it down, and it's ANP that does that function. So we got renin and norepinephrine and epinephrine. Let's talk about them first. So let's say that there is a stimulus that is going to require an increase in blood pressure. Let's say that stimulus is an emergency situation. You're getting chased by a moose. Those guys are nasty. Okay, so we got an emergency stress response. What do you want to do? Do you want to put energy into making more urine while you're running from a moose? Or do you want to stop blood flow to your kidneys and make more blood flow out to your muscles and your brain so you can get away from that moose better? In a stress response, this is going to cause all of our GFR to drop. We know that's going to be the end of the story. Okay? The stress response wants to decrease GFR. We don't want to pee more. We want to decrease GFR. We want to decrease the amount of blood being filtered so that that blood can be diverted to another area of the body that needs it while we have a stress response. How does this happen? Okay, this is going to happen through two different mechanisms, both inside of the kidneys that we're going to be talking about here. The first thing we want to talk about is the release of norepinephrine and epinephrine. So norepinephrine and epinephrine, well, let's actually talk specifically about epinephrine here, or sorry, norepinephrine here. Because norepinephrine, it's the primary one that activates alpha-1 adrenergic receptors. That being said, epinephrine can do it too, just to a lower affinity. But we're going to focus in on norepinephrine for the sake of simplicity. Norepinephrine is released from the adrenal medulla or from a synapse as a neurotransmitter, and it's going to activate receptors. So this norepinephrine is released, and it starts to activate alpha-1 adrenergic receptors. Where are these alpha-1 adrenergic receptors found? They're found on arterioles. Most arterioles of the human body are covered with alpha-1 adrenergic receptors. Were there any arterioles that we've talked about already? The answer is yes. We've talked about the afferent and the efferent arterioles. So if it binds to the alpha-1 adrenergic receptors on the afferent and efferent arterioles, these are excitatory. If an adrenergic receptor has one, then it's an excitatory adrenergic receptor. So this is going to excite the smooth muscles around the arterioles and cause vasoconstriction. So now we're going to have I almost spelled that wrong, constriction of the afferent and efferent arterioles. And when we vasoconstrict, we make the diameter of the tubes going in and out, but we don't care about out, we care about in. We make the diameter of that tube smaller. And when that diameter of the tube gets smaller, blood flow into the glomerulus decreases. Okay? This is going to decrease blood flow. And the second we decrease blood flow into the glomerulus, now there's less blood inside of this glomerulus, and that's going to start dropping the hydrostatic pressure inside of that glomerulus. And as the hydrostatic pressure drops, the pushing force that drives net filtration pressure is decreasing. So our NFP starts to drop. And if NFP drops, GFR drops, which is what we were after to begin with. We were saying, If you're running for Mr. Axeman, do you want to pee more or do you want to pee less? You want to pee less. We want a decrease in GFR. How does that happen? Boom. That's one of the ways that this can happen. Norepinephrine binds to the alpha-1 adrenergic receptors, which causes vasoconstriction of the afferent and efferent arterioles, decreasing the blood flow into the glomerulus, causing a decrease in the hydrostatic pressure inside of that glomerulus, thus decreasing the net filtration pressure that can occur, which will now directly affect GFR. The second response that's going to occur you guys can rewind that and copy that down. The second response that's going to occur when we release renin, norepinephrine, epinephrine is actually the fact that norepinephrine and epinephrine stimulate the release of renin. So these guys here actually activate the release of renin from the kidneys, from those granular cells of the kidneys. Hopefully you've been learning your anatomy. The granular cells surround the afferent arteriole, and then they secrete renin. And renin's job is to, not so much, right? Activates Ang1, which then get activated into Ang2 by ACE, and then Ang2 does like everything. Ang2 is a really powerful hormone to increase blood pressure. And that's no different here. When we activate renin, the end result of renin being activated is we're going to get an increase in the activation, A with an arrow up, of angiotensin 2. And Ang2 is a really powerful hormone that does everything from thirst, vasoconstriction of arterioles through the body, so forth, so on. But something else that it does is it causes our glomerulus to contract. So Ang2 is going to bind to receptors in the glomerulus, and it causes that glomerulus to contract. So take your hand, put it in front of your face, and squeeze it down. And if we can contract the glomerulus, what are we affecting? We're affecting the filtration coefficient. Actually, we'll keep that in for later. We're affecting the filtration coefficient. We made the surface area smaller. We made the membrane permeability smaller. This decreases the surface area and the membrane permeability. And when we decrease the surface area and the membrane permeability, we decrease the filtration coefficient. And if you decrease the filtration coefficient, then you decrease GFR even more, which is what we were after. We said, if we have a stress response, we want to decrease GFR. What two ways is it going to do that? One, norepinephrine activates those alpha-1 adrenergic receptors, causing vasoconstriction of the afferent and efferent arterioles, but decreasing the size or diameter of the afferent decreases blood flow into the glomerulus. Decreasing hydrostatic pressure in the glomerulus, decreasing that filtration pressure, which results in a decrease in GFR. In addition, epinephrine, norepinephrine activates renin. Renin activates Ang2. Ang2 causes glomerular constriction or contraction of something called mesangial cells, if your professors are asking you to learn that part. So the mesangial cells are smooth muscle cells that cause the glomerulus to tighten down into a fist, thus decreasing the surface area and increasing membrane permeability, decreasing membrane permeability, resulting in a decrease in GFR. That's how. That's real physiology. That's taking all the pieces of the puzzle that we've learned right now so far through hopefully all your A&P career and tying it into one cohesive package. There's even more in terms of what happens at the cellular level, but my classes don't need to know that, so I'm not teaching that in these YouTube videos. The other hormones, The other hormone that we said affects GFR. Everybody take a nice deep breath. I'm not going to write this one out. I'm going to just say this one. Okay. This is ANP. ANP. So the stimulus for the release of norepinephrine, epinephrine, renin, this stimulus was anything that tries to decrease GFR. So if GFR, or sorry, the other way around, anything that causes a decrease in GFR stimulates the release of renin, norepinephrine, epinephrine. Whereas AMP is going to be triggered by an increase of GFR. And the body's going to be trying to fight that. It's going to say, GFR is too high. Let's get GFR back down again. Let's write down something here. Stimulus. The stimulus for the release of norepinephrine, epinephrine, renin is a decrease in whatever, right? If there is a situation where we want to bring blood pressure through the body up and decrease GFR. So that could be a decrease in our mean arterial blood pressure. And if we decrease mean arterial blood pressure, boom, we start secreting renin, norepinephrine, epinephrine. Right? When you're running for Mr. Axeman, blood starts rushing out to your skeletal muscles, and that right off the bat triggers a decrease in blood pressure, and then your body's going to try to bring them back up. Versus the stimulus for AMP is going to be an increase in blood pressure, which causes an increase in GFR, and then our body's going to try to oppose that. This is the stimulus, not the result. Now, AMP does the opposite of norepinephrine, epinephrine, and renin. So look at your flow charts for these two hormones and then do the opposite for AMP. For instance, AMP causes vasodilation of the afferent arteriole. So if the afferent arteriole vasodilates, it gets bigger in diameter, more blood flows in. And if more blood flows in, hydrostatic pressure starts to increase. And if hydrostatic pressure starts to increase, then NFP increases. And if NFP increases, then GFR increases. So ANP has a direct effect on blood flow into the glomerulus. In addition, ANP directly inhibits renin. ANP binds to those granular cells that secrete renin, and it says, no, not today. AMP directly inhibits the secretion of renin. Once we stop secreting renin, renin stops converting angiotensinogen into Ang1. Ang1 stops being converted by ACE into Ang2. And if there's no Ang2, then the mesangial cells in the glomerulus relax. And once we get rid of that Ang2, the glomerulus relaxes. And when the glomerulus relaxes, the surface area increases, the membrane permeability increases, thus the filtration coefficient increases, all of which increases our GFR. Neuron function. GFR, glomerular filtration rate. This is the ultimate of the nephron function. We can completely describe GFR function by understanding a couple of formulas. And using these formulas, we can understand any hormone effect, any disease effect, any normal phys versus any pathophys, right? We can say, if these variables change, if any of these variables change, what would happen to NFP, therefore what would happen to GFR? Or if any of the filtration coefficient variables change, what would happen to GFR? That's what we're after. The ultimate understanding, the ultimate learning. You've got to practice this and ask yourself, what would happen if I changed any of these variables? And boom, all of a sudden, You're going to go from memorizing things to learning things. All right, best of luck in your studies. Humankind, be both. Be nice to yourself. Be nice to your neighbors. Till next time.